Thanks, Bob. I appreciate being invited to give probably somewhat of a controversial or a discussionable methodology for preventing pseudoarthrosis and multi-level constructs. So the picture to the right is worth 1,000 words. On the left, you see the traditional long plate. On the right, you see multi-plates. But it all goes back to a single plate. A small 15 millimeter tall plate with hyperangled screws for single level fixation at multiple levels. And that's actually a newer advent in the last 5 to 8 years or so. We didn't have plates this small till very recently. So you couldn't think about stacking them up like this in multi-level. So this is the science behind, so how many fellows are here today? We got Zach. Zach, can you explain this for us about the compression? Okay, I had to pick on a fellow at least one time. So we can spend an hour doing that, or you can just give me for today that if you have an angled, hyperangled screws and a short plate, you get compression across your graft. All right, we won't discuss it anymore for now, but you can come back to it later. History teaches us everything. So ACDF started in the 50s. It usually, before that, was the back of the neck, it wasn't the front. And Smith and Robinson taught us the word indirect decompression. Thought that was new at lateral surgery, but this is where it really was talked about mostly. But Cloward, a very intelligent and smart neurosurgeon, said, but you still got to decompress. So it created a technique that gave us more decompression. Eventually, these techniques were adopted, and anterior surgery started to take over, but plating trailed behind. And plating really came about through trauma and instability, not for primary degenerative disease or ACDFs. And so, what happens is, in the beginning, it's used for one thing, and then it transfers to another, and then to another, and then we start to see the advent of Casper plate, one of the first successful plates. But look at the drawing. It shows a plate in the center, this little sketch, and it shows the plate lying over it and abutting both adjacent levels. And the plate is very wide and very long. So the original biomechanical theory was you have to have a big, robust, massive plate. And we all know what's going to happen if you do that today. You're going to get adjacent segment disease. You're going to get more surgery. So not faulting them, but that was the biomechanical theory at the time. And these plates were good. But they had a lot of different problems. But of course, we started to use them for degen. Degen started, and here's the interesting thing. We didn't start with single level. That was unheard of. Back in those days, if you put a plate on a single level, you're a bad doctor. You're just doing that for money. We started with multi-level, 3 and 4 levels. Okay, so what happens then? So we learn in reverse. We learn from multi-level fixation, and then we go down and we argue and debate, 4 levels okay, 3 levels okay, 2 level, never. You never need a plate on 2 levels. We finally agree, okay, 2 levels, there's advantages, and then we finally get to that 1 level issue. But the usage was adopted based upon stabilizing unstable spines, preventing graft extrusion, the need for internal fixation and early mobilization, and then sagittal alignment. All good principles. So yeah, plates are good. These were the problems with the original plates. They were bicortical, variable angle. They backed out, and the screws backed out a lot, and there was a lot of loosening. No fault. That was the initial plates. And so plating advanced and improved. And then go back only 20 years, and here's a really good article about why we have a horribly unacceptable rate of pseudoarthrosis at 3 and 4 levels, and plating doesn't really help. And then about the same time period, yeah, but we get less pseudoarthrosis, although not statistically significant, and so why don't we use a plate? Because we're getting less, although still not a great outcome in 3 or 4 levels. So plating starts to take adoption at higher levels, 3 and 4 levels. And then it comes down to the 1 level. And even in this article, this is only, 20 years ago or so, there's a question of, does a single plate cause a problem with fusion? That was one question then. Is this done incorrectly? To this one, 2004, only 17 years ago, the only time you use a cervical plate if the patient won't wear a collar. Other than that, you should never use a plate. So look at the debate, and it's not that old. It really isn't that old. So here's the primary question for my talk. Why does the preponderance of the literature demonstrate an increased pseudoarthrosis rate with multi-level ACDF versus single level? Why? Nobody has the answer. I don't either. But I have one proposal. And then, so what's the cause of it? We know it's real. We know it's happening. Most literature supports that, and we know it's true. But think about it for a second. At each level, we're doing the same thing. We're doing the same decompression. We're putting the same inner body, the same graft. So what is it that changes that makes the increasing number of levels we do have a higher failure of surgery? Well, one really intelligent surgeon told me we're losing the number of osteoprogenitor cells. You don't have as many around in 4 levels. No way. Another very intelligent surgeon said, you get tired. You're not doing as good a job in the 4th level. Nah, that's not it. So I haven't had a good explanation, so I got my own. And then, so does the use of a single long plate apply a differential fixation, right? I mean, are all levels being treated equally in a long plate? And then if you have a 3 or 4 level ACDF, would a segmental plate act like a single plate at multiple levels? We all know a single level fixation is 95 to 100% fusion. You just can't miss. Closer to 100%. Why is it going down as you increase the levels? So my hypothesis was, if you do individual single-level ACDFs, you should have an equivalent and balanced biomechanical force across that disc space no matter where you do it, right? And the biomechanical forces should be equally distributed around that fusion graft. Single plates are much more easily placed in a long, big plate after 4 levels. So here's the question again, this or this? So we did a quick review of some of the more current literature on 3 and 4 level ACDFs, and we have about an 89% fusion rate. It's improved from the 60s, 70s, and 80s. 89% is not terrible for a 3 level. It's not 99% like a 1 level. And if you're the patient, it's 1 in 10 are failing. 4 levels, still not that great, 79%. All right, so that's just it's not a meta-analysis, but it's an idea. So this is the bottom line data from a study we did, a retrospective review using single plates. This is all-inclusive of 1 level, 2 level, 3 level, and 4 level, whether you use allograft or BMP. Yes, my name is Rick. I can't stop using BMP. I just keep using it and using it. I can't stop no matter what I do. I use it in the neck, but I use a very, very low dose, extremely low dose. And when you dose it really low, all the issues that were in the literature don't ever happen. It's a dose-related problem. We were way overdosing them in the beginning. We created all that swelling. It doesn't happen. I always thought my high fusion rate was because of BMP, until my partner, who only uses allograft, who does segmental plates, got exactly the same result. So BMP is not of the benefit that I thought it was if I get this kind of result with allograft. So overall, a very high fusion rate, and one we're looking for whether you do 1 level or 4 levels. But here is the slide. This is the bottom line in our data. So whether you use allograft or BMP, look at single level on the left and then 4 level cases on the right. Yeah, BMP's got a little bit better number, but 91% fusion rate, 92% fusion rate for 4 levels versus 96 is a better day than 79%. It's a much better day. And that's where I think the tire meets the road. The complication rate's very low. The subsidence is almost non-existent because you're balancing your forces, and the revision was very low in this series of patients. So again, advantages. The biggest advantage, and the reason, my primary reason in multi-level is to get a high fusion rate. We're here to fuse. We're here to fuse, decompress, and align. And Chris Shaffrey made the best point of his talk, and although it was a great talk with other points, we got to get the sagittal alignment correct even at 1 or 2 levels. We're creating all these spinal surgeon annuity program with these adjacent levels. And so we got to get that balanced, even 1 or 2 levels. And I would say it's easier to balance each disc level if you do it segmentally. Maybe another advantage there. And then, of course, the ease of placement. We're all very, very good at a single level plate. We're all really good at it. And so you don't have to have a special talent for something more than that. And then the prevention of ALOD. You don't want to get into the adjacent soft tissues, and so these plates can be placed really, really far from the adjacent level. That's probably a major benefit, and you can do it 100% of the time, which you cannot do with long plates. It's too hard. Usually one end ends up being longer than the other. And then, what about an adjacent level? No matter what you do, you're going to end up with a level next to your fusion that has to be fixed, even with this technique. So you come in and you do it completely index procedure again because you have a large area to place your plate. You don't have to remove plates in the future, so looking ahead. And then what about if you have a pseudoarthrosis in a multi-level plate, single long plate, or you have segmental plates? Well, you take this little plate off and fix that level and get out. You don't have to deal with a big plate cover and having to remove a big plate or taking a metal cutting burr to burr it off to get back in there. You just undo the one plate you worked on and you're out. So it's nice for planning ahead for the inevitable. This is an illustrative case study. Classic problem we see in Melbourne, where I am, is God's waiting room. Everybody's got 3 and 4 level disease, every patient, it seems like. And so we have to have a successful strategy for them. We use a bolster under the shoulders, and then we cock back the head of the table and get a nice neutral position for the neck. So this is showing pre-op, and the first picture. The second is after removing all the disc, all 4 levels, and then there's a repositioning done after that because the neck is looser. So we place a fulcrum behind the neck to get a little bit more, and then there's post-op. And what happens is you see an incremental increase across the board of lordosis. In total here, 19 degrees from the lordotic measurement of C2 to C7. From the operative levels of C3 to T1, we see even more. So in the operative levels, you're getting a lot of improvement, and you're doing it harmoniously through small changes at each level, but better than a big change and rapid change at one single level. And then it's maintained, so the pre-op final positioning into surgery and 3 months follow-up, we're seeing that this is fairly well maintained. 11 degrees increase. Now you see a 47 degree in the middle and a 39 in the end. Well, C2-3 is hyperextended in intraoperatively, and it gives you a false lordosis. And so when the level's treated, same phenomenon, 24 degrees. And then the SVA, it goes from +1 to -1. And once again, the -2 in the middle is because of C2-3 being hyperextended place in the body of C2 posteriorly. We went ahead and measured every level. And I'll take you to the only complex busy slide we have, and we're done. So just take a second to know that the red is the pre-op, the purple, the next level is post-discectomy. Remove all the disc, loosen the neck up. The third is orange, and we're repositioning now, taking advantage of that looseness of the neck. And then we do our end positioning in green, and then we do a 12-week follow-up in yellow. And what we're seeing is incremental increases at almost each level we operated. You see 0 on the left because we didn't operate at C2-3. It didn't change much. But we do see an effect of repositioning in each and almost every level. So there's something to it to actually, once you do your loosening of the neck, then reposition a bit and get more lordosis, and that's better than trying to force it with an expandable cage. So to conclude, there was no statistically significant difference in fusion rates between 1 and 4 level surgeries using segmental plates. It certainly represents an improvement over our current literature in 4 level cases. The longer screws that you get from hyperangulation may also assist in creating that fusion rate, and the increased angulation might contribute to the high fusion rate by compression. If you stay 5 millimeters or more from the adjacent level, you can mitigate the adjacent segment disease, which you can do 100% of the time using a segmental plate. We're all good at it. It's a single plate. It goes on perfectly every time there. All right, thank you very much. So I'm sure, thank you. I'm sure there's no questions about that, and so I'll just go on to the dissection.
It's a very uncontroversial topic, yes. So I had a couple questions, and then I'm going to pass the microphone over to my colleague, Jens Chapman, who when I've shown similar cases, he's been, let me say, appropriately skeptical, so I'm going to give him a chance to make a comment. So the first question I have is, how do you deal with the cost of multiple plates? And do you see a future where companies are going to reduce the cost of the plates to make this, you know, I'm not sure equal, but close to equal to using a single plate? I've heard cervical plates called a commodity by people in the implant industry, and so I guess what I take away from that is really the manufacturing cost and the innovation cost around plates is relatively limited. So that's the first one, the economics. The second one was a technical question, and you said you use a very low dose of BMP. Could you expand on that and just describe exactly how much you're talking about?
Yeah, the cost is critical. I mean, if we can't afford to do something, we can't afford to do it. I don't know what the cost is of revision rates from pseudoarthrosis and how that compares to the additional cost of plates. What I've done with my vendor is they get a premium for multiple plates, and we've agreed that when I use multiple plates, they get a premium over a single long plate. That's it. And that seems to work for them. So they're getting a premium for, they're actually making a little more than they would with a big 4-level plate, because the plates can cost more as you make them bigger. That hasn't been an issue so far, and I guess you'll have to work with your individual vendors. I have a suspicion that if you said, well, if you can't do that for me like they do it for Heinz, I guess I can call his company. They seem to be having no problem with it, and the payers are not having a problem, the hospital's not having a problem. I thought there'd be a lot more resistance, but there hasn't been. As far as the BMP, yeah, I mean, in the beginning, when I think about the amount of BMP I put into a lumbar segment, an entire large kit, it blows my mind. The original LT cages, I mean, the massive amount of BMP we were using, it was probably 5 times what we needed to get it to fuse. And over the years, we learned to use less. We found that bottom level. I had the same experience in the cervical, same experience we all had with swelling and that risk. I've never had a patient have a life-threatening risk. They had some swelling, and I understood what it was. So we reduced the dose, and now it's down to somewhere between 0.2 and 0.3 millimeters. It's a teeny dose. It doesn't take much. But I have to tell you, I mean, I've been a real advocate of BMP in the neck at extremely low dose, despite all the controversy, until the study, and realized that, well, it's not the BMP that's giving me my advantage. It's the segmental plate. And so I'm not really trying to push BMP at all. In fact, I think if allograft can perform as well as BMP, I prefer to see allograft, so we don't have to take any risk, and it's less expensive. So the study taught me something. I was convinced my high fusion rate was totally dependent on BMP and wasn't anything else, but I don't think it is. I think it's the biomechanical effect of the methodology. Now
I have a question for alignment. So I saw that you made a very hyperlordotic alignment with the multilevel ACDF, but that's not, sometimes the hyperlordosis can make some compensation kyphosis of upper cervical spine and T-spine. So what did you see the follow-up, the alignment change with the hyperlordosis?
Well, yeah, I mean, the goal here in the talk was really just to talk about a technique, and the demonstration will be how you do it. How much lordosis you create is really up to you, and based upon what you think your needs are. Obviously, we don't need a tremendous amount in a degenerative spine that's already in balance. You barely have to do anything. Only 10 or 20 degrees would be plenty. So this one's overdone a bit, but I think you can control that. You can make whatever. It's the idea is that you can get more lordosis if you need more lordosis. And looking back at the last presentation on corpectomy, and there was an excellent question about, well, when do we do a corpectomy? When do we do a multi-level? I think multi-level is a little easier to do than a corpectomy, and when I can do that, I'd rather do that. And so I can get more lordosis with this methodology than I can with a single long plate for many things. However, with a significant kyphosis, I still use a long plate. If it's a really severe kyphosis, long plate corpectomy, that's not what this is really about. It's about degenerative disc disease, multi-level, and getting a high fusion rate. And then I think you can adjust your lordosis as you need to. Any more questions at all?
This is always very compelling presentation, interesting thoughts. I second Bob's statement. You're a visionary, and it's cool to have somebody who thinks outside the box. Just putting on my SSF hat, SSF does not endorse the off-label use of BMP in the anterior neck. This is a black box warning. I'm not against it. I'm not endorsing it, but SSF is not facilitating the promulgation of use of BMP in the anterior neck. So that's just something from an SSF standpoint I just want to point out. And significant retropharyngeal swelling has been reported in the past, and is a potential adverse side effect. So I ask all who listen to this to take this into consideration. Obviously, use of BMP makes any analysis of the benefits of a multi-segmental individualized plate fixation far more difficult because you have different variables at place. For me, the big question is, Going back to Professor Casper and his wonderful plate, who I actually got to see live in person, I'm that old. He was a very, very detailed surgeon. So he had near bicortical or bicortical screw fixation with a somewhat dynamic loading system with the oblong screw holes. So between the biomechanics of having lordosis, not too much end plate resection, a biologic feature, and then having the long screw fixation, how can we really assess the benefits of a segmental plate fixation over unit plate fixation, number one? And number two, where's the biomechanics testing that shows load to fatigue, specifically the long-term fatigue like 10,000 cycles plus, does not weaken the bone in between? We've had some failures here of segmental plate where the bone basically broke between the plates. So that's my biggest worry, the biologic ability of the host bone to withstand cyclical loading. Thanks.
Yeah, no, I'm not advocating or not advocating BMP, so let me be clear about that. I just showing you what I did and what I've actually been pleased to see was the allograft response. A really high response, which is what makes me happy, because I use BMP because of the high failure rate in multi-level. So, we have a large failure rate in 3-4 levels, and you're going to get a pseudo every other time. Well, I'd rather take a little risk with the low-dose BMP to make sure that doesn't happen, because it's a risk-benefit ratio. But that's not an advocation. And I was excited about allografts. So I think allograft's the way to go. I mean, allograft or other, but now if you use segmental plate. As far as failure between the segments, I've never seen one. I've never seen it. And I've done hundreds and hundreds and hundreds of these. My partner and other partners have done this. That's our routine operation. So I can't speak to a failure of the vertebral body between the segmental fixation. I can't explain that. All I could think of is perhaps there's an over-decortication and a subsidence of the implant, and it may be a technique-mediated problem. I don't ever take off the cortical surface. I just simply scrape the cartilage, and it's a rock-solid cortical surface, which allows me to have a minimal subsidence. That's the only explanation I could possibly think of. Other than that, I've not seen it in hundreds and hundreds of patients all these years. So any other issues or questions?
Well, that's one.
One further question I'd ask. To me makes intuitive sense and intuitive mechanical sense, and it strikes me that it'd be a very straightforward, biomechanical study to perform. Has that yet been done? Are you aware of the results, or is that yet to be done?
No, it has not been done.
Yeah.
It's being done.
Yeah. Okay.
But it's not done.
Yeah.
And I don't understand at all why you would fail in between. That's something odd is going on in the technique.
Yeah. I'm not familiar with the patient that Jens is referring to, but it's something I'm kind of wading in on. I haven't done the kind of experience that you have. I've also done some now where I've done a 2-level plate with a 1-level plate. Mm-hmm. And I will say the one issue that I do run into is, and I may be doing a slightly wider discectomy than the average surgeon, but I end up not having enough space at times to stack plates. Can you comment on that? I think there are now some asymmetric plate designs that are coming forward that'll allow that a little more easily.
Yeah, I haven't had a case yet where I can't stack them. Now, there have been a few really small necks with small vertebral bodies where even the 15 millimeter plates, they basically touch. And one was in a cardiologist I fixed, and he said, "Hey, this is great, but I hear the squeaking sound." So as he was healing, there was still a little movement, so the titanium was squeaking. I said, well, the good news is it means it's okay, and your wife will know when you're coming. The bad news is it's going to stop squeaking when it fuses, and then she's going to be surprised again. And so it made him laugh and realize that it's just a phenomenon of the titanium touching, then it stops when it heals. So 15 millimeters is a pretty small plate. I mean, it's basically almost just, it depends on your inner body size. If your inner body size is real small, like a 5 or 6 millimeter, and you stack those up, the plate's going to extend over further. If you're at 6 or 7 millimeters, 8 millimeters, the plate's just going to cover it's going to be edge to edge with the inner body implant, and there's no way they're going to connect to each other.
Can I ask a quick follow-up?
Sure.
Thanks, Dr. Hunt. That was a very fascinating talk. Just two quick questions. One is, has this, in your practice, obviated the use of posterior surgery, or how do you define that role? And then the other one is, there's some publications on the use of incorporated standalone devices with plate placement as well for multi-levels to diminish the pseudo rate. Do you have any experience with that relative to this?
There's publications on segmental fixation for zero profile.
Right.
But I haven't seen anything robust that has plate fixation with it. And the reason why I use plates and not just zero profile, because the zero profiles, they don't maintain the lordosis. And they all flatten out. I mean, I like the idea of zero profile. I like the idea of segmental fixation, but I add the plate to preserve the lordosis. And what we've seen in our study is that the lordosis is preserved with the plate fixation. That's critical. And I'm sorry, what was the first question?
Oh, the role of posterior surgery now in your practice.
Yeah, absolutely. I mean, I rarely go posteriorly. I don't like to be posterior. The patients do so much better anteriorly and so much easier for me. I know there's a debate after 3 levels, go posteriorly to get a high fusion rate. Well, I think that's true because we don't know why 3 and 4 levels fail. We still don't know. I mean, my talk doesn't answer the question. All it does is probe the question so that we start thinking about why are we getting this higher rate of failure at 3 and 4 levels over 1 level? What exactly is happening? And why do we have to go from at 3 levels or 4 levels to posterior to make sure we get that high fusion rate? I'd rather use segmental plates. That also may answer part of the question on cost. What's the cost of 3 or 4 segmental plates versus a long plate and then a posterior surgery to get a high fusion rate? Because the goal is high fusion.
Thank you.
One last question. Can you, you mentioned that you like allograft, but your x-rays all seem to have, I think it was a peak interbody cage. Are you filling the cage with allograft? Is that what you're referring to, or did you mean something different?
In that particular group of patients, my partner was afraid of BMP like everyone else, and he stopped using BMP when the studies came out, although he had BMP in his neck when he had surgery. He chose that. He used all allograft. And so we just started looking back at the allograft versus the BMP, and it was a shock to me that I said, well, I'm going to beat you bad. And with BMP and segmental plates, you cannot get the results I'm getting. You got almost the same results with allograft. It tells me it's got to be the plate fixation that gives us that benefit segmentally. I don't think stacked up 4 allografts on a long plate will compete with individual plate fixation and allograft.
So you're talking about structural allografts then?
Yes, yeah. And the ones I'm using are P cages with BMP.
Right, got it. Okay.
All right, thank you.
Thanks again, Rick. Great talk and compelling story, I think.